Acute and Chronic Renal Failure by Emily and Stephanie. RF is a 45-year-old female baker. She first presented with acute renal failure secondary to gastroparesis. Her current diagnosis is chronic renal failure. Past medical history includes an ovarian adenocarcinoma, which was treated with bilateral salpingo-oophorectomy. She was dehydrated but hemodynamically stable. She had a tender swelling in her upper abdomen. The ultrasound showed marked distension of the stomach without evidence of renal tract obstruction. She did not respond well to fluid replacement. Here is a list of definitions that you can refer back to throughout the presentation. Prevalence. By the end of 2009, there were more than 871,000 people being treated for end-stage renal disease in the USA. Between 1980 and 2009, the prevalence rate for end-stage renal disease in the USA increased nearly 600% from 290 to 1,738 cases per million. 10% of the world has chronic kidney disease. Millions die each year because they do not have access to affordable treatment. Etiology. For acute renal failure, causes include nephrotoxins, which are drugs, chemicals, or toxins that cause tubule necrosis and obstruction of blood flow. Ischemia, or more specifically, severe and prolonged circulatory shock or heart failure, which eventually leads to tubule necrosis. Pyelonephritis, or mechanical obstructions such as calculi, blood clots, or tumors which block urine flow beyond the kidneys. And any acute bilateral kidney disease that reduces glomerular flow rate, such as glomerulonephritis. Causes of chronic renal failure include nephrosclerosis, diabetes mellitus, nephrotoxins or long-term exposure to it, chronic bilateral kidney inflammation or infection, and polycystic disease. Pathophysiology for acute renal failure. The onset is sudden and acute. There's a decrease in blood flow into the kidneys, and also a decrease in glomerular flow rate and either oliguria or anuria due to inflammation and necrosis of tubules, creating an obstruction and back pressure. Both kidneys are involved in this disease. Pathophysiology for chronic renal failure. The onset is slow and insidious and occurs in stages. In the first stage, there's decreased reserve and 60% of the nephrons have been lost. There's no apparent clinical signs. There's a decrease in GFR. Serum creatinine levels are consistently higher than average. In the second stage, there's renal insufficiency and 75% of nephrons are lost. The symptoms become apparent. There's a change in blood chemistry. GFR is decreased to 20% of the normal. There's significant retention of nitrogen wastes, such as urea and creatinine in the blood. Tubule function is decreased. Osmotic diuresis occurs as remaining nephrons filter an increased solute load. The stage is marked by excretion of large volumes of dilute urine. There is a decrease in erythropoiesis and an increase in blood pressure, which causes the cardiovascular system to compensate. In the end stage, there is uremia, where more than 90% of the nephrons are lost. The GFR is now negligible. Fluids, electrolytes, and wastes are all retained in the body. All body systems are now affected, and there is marked oliguria and anuria. Regular dialysis or a kidney transplant is required for survival. Diagnosis. Key indicators are anemia, acidosis, and azotemia. Metabolic acidosis can be found in the late stage, where a serum pH level below 7.35 indicates renal failure. Azotemia. This is indicated by a presence of nitrogen wastes in the blood and elevated serum creatinine and urea levels. When anemia is severe is also an indicator, and serum electrolyte levels may vary depending on the amount of water retained in the body. Clinical features. Children with renal failure have delayed growth and renal rickets. Acute early signs include rapid development, oliguria, blood tests that show elevated serum urea, nitrogen, and creatinine, metabolic acidosis, and hyperkalemia, and these signs confirm the failure of the kidneys to remove wastes. Acute progressive signs include recovery, where we eventually see increasing urine output, or prolonged failure, where you see uremia. For chronic renal failure, early signs include increased urinary output with dilute urine, which is called polyuria, which is manifested by nocturia. General signs of anorexia, nausea, anemia, fatigue, unintended weight loss, and exercise intolerance develop. Hypertension, bone marrow depression, and impaired cell function caused by increased wastes and altered blood chemistry. Chronic progressive signs include end-stage failure or uremia, oliguria, acidosis, azotemia, dry, pruritic, and hyperpigmented skin, easy bruising, general muscle weakness, peripheral neuropathy, abnormal sensations in the lower extremity, loss of grip strength and dexterity in hands and fingers, impotence, and decreased libido in men, menstrual irregularities in women, encephalopathy, which include lethargy, memory lapses, seizures, and tremors, congestive heart failures and arrhythmias, urine-like breath odor in terminal stage or if infection is present, systemic infections such as pneumonia, and edema in the lower extremities. IFC model. Body functions and structures affected include lower extremities, fingers and hands, and muscles affected by fatigue. Activities affected may include toileting, feeding, cooking, home management tasks, prolonged standing, walking, climbing stairs, or any physical activity, any tasks requiring functional grasp and finger dexterity, such as writing, typing, texting, cooking, baking, crafting, holding utensils to eat. Participation may be affected, such as, in our case, being a baker, being a mother and wife, participating in family outings, being an active member of the community, and attending social events and outings. Medical and surgical treatments. Dialysis. In the uremic stage, it is used to normalize body fluids and maintain homeostasis during the oliguric stage. Recovery from acute renal failure can be seen with increased urine output in the diuretic stage. Forms of dialysis include hemodialysis and peritoneal dialysis. Kidney transplant is also an option, where one kidney replaces the function of two failing kidneys. Your own kidneys are left inside your body unless it is creating infection or high blood pressure. Drugs are available to stimulate erythropoiesis and reduce phosphate levels, to treat hypertension, arrhythmia, heart failure, and other complications. The dosages are carefully managed and very specific since the kidneys cannot excrete drugs in a timely manner. And these are our references. Thank you for listening.